you, Brian, and thanks for the invitation to speak to an impressive number of people online. What I thought I'd do is just summarise CLL briefly, because we have, I think, people who are touched by CLL at various different stages, from stage A through people who've had lots of treatment, and just talk about that pre-COVID and the treatments that were available and were in trials, and then maybe talk a bit about how COVID has affected hospitals generally, just to give you a feel for what we've been doing in our hospital, and it's very similar to many other hospitals, and then try and address some of the bigger issues that have come through with the questions in terms of shielding and risk and immunity, and then leave lots of time for questions, if that's okay. So I think we'll have on the line patients who maybe just have been diagnosed recently, or other patients who may have had the disease for 20, 30 years, and some patients who are, 90% of patients at diagnosis are found incidentally nowadays with usually a blood count, or maybe they find a swelling and are stage A disease, and therefore would not need treatment, although we know from an amount of research that that certainly has an effect on patients or people's quality of life in terms of the stress of the diagnosis, the watch and worry, being told you have a leukemia and then being told that we're not doing anything about it. Some flippant comments about good leukemia, which is a phrase I would never use. I mean, nobody wants to have a diagnosis such as CLL. To patients who are now maybe progressing through treatment or towards treatment, and historically, certainly when therapies were more toxic, perhaps we've delayed treatment, and many patients have had symptoms and have not wanted to be treated for some time. And I often say, we have patients that we, for example, with FCR, may have delayed treatment for 2, 3, 4 years with symptoms. Then when we treat them, the patient feels better than they've done for 3 or 4 years. So the fear of treatment has delayed our approach. And then patients are obviously on treatment with different aims. So and I'll talk about the risk between the various stages later on. In terms of the treatment prior to the COVID crisis now, we really would only treat patients who have progressive symptomatic disease. And the reason for that is really two or threefold. First of all, we've done trials in the past with, admittedly, the older therapies, although ibrutinib has been used in a similar trial recently, of patients who have early stage disease, and we do not see any benefit for treating patients earlier. Secondly, half of the patients who present with early disease will never need treatment. So we will be exposing those patients to risk, even if it's a well-tolerated treatment. Half of those patients will never need treatment, and therefore, we'd have to see a very big benefit to see an advantage. And I guess as we get more effective therapies in the last 10 years, I mean, I've been working on CLL now for 25 plus years running trials. In the last 10 years, we've seen a dramatic change in the outcome of patients with CLL treatments. And I think it is realistic now that we would expect patients, the vast majority of patients, have very good responses to treatments. And I think we're even thinking of moving towards cure for patients, although that's a very hard thing to prove. And so as we get better, more effective treatments, the requirement to treat earlier is less, and actually there's a reason to delay because the treatment is moving so quickly. What we're using now, we didn't have available to us 1, 2, 3 years ago, and that's going to carry on, I think, as we move forward. Having said that, it's important we do not delay treatment beyond the time when patients are suffering from their disease or progressing. So in terms of therapy outside of a clinical trial, we'd assess patients, first of all, obviously clinically, and how well they are and what they want from their treatment or their disease, but also the biology of the disease. And so we would, when we're going to treat a patient, we would look at in much more detail at the underlying problem. And not every CLL patient is the same, as you know. Some patients don't progress, some patients do progress, some patients have big lymph nodes, some patients have lots of symptoms, other patients don't have any symptoms. And so it's a very wide spectrum. And we have, through a lot of work both in the UK and beyond, a lot more information about the disease and which patients are likely to respond to what therapies, are likely to progress. And one of the critical, certainly from our point of view in the UK, when we decide we're going to treat patients, is whether we have this deletion of 17p or T53 mutation, because that would mean that we wouldn't give those patients chemotherapy. That's a small proportion of patients. It's 7 to 10% of patients that we need to treat, but it's important we test for that. Outside of a clinical trial, that we know that FCR, and this is the combination chemotherapy of therapies like cyclophosphamide rituximab, which is, if you like, most effective chemotherapy, but also with side effects, can be very effective, and a significant minority of patients may never need treatment again. So when we are doing clinical trials, or when we're talking about moving to new therapies, we have to consider that we don't want to lose the advances we made in the last 20 years. For example, with FCR driving patients into very deep remissions. The problem with that is that the side effects of FCR, as many of you may know, are not trivial and can be very serious. And so it's a balance to be had. The things that have changed in the last really 10 years have been based on our understanding of the biology of the disease. So we know that CLL cells that are growing out of control have two major problems. One is they're growing too quickly and are switched on to grow continuously. They're mimicking normal lymphocytes, but they're just growing all the time rather than switching on and off. And secondly, they don't die when they should die. So a normal lymphocyte, when it's done its job, got rid of measles, whatever it's attacking, has to kill itself and be recycled. And that's a process as well. So those two processes, the cell growth and the cell death, are what goes wrong in a CLL cell. And that's led really to the changes we're seeing in the treatment of CLL, the so-called targeted treatments or novel agents. And so there are two real classes of the ones we use. Ones that stop it growing, and the ibrutinib will be the one that's approved, and I'll talk a little bit about acalabrutinib because that's becoming available. And therapies that make the cells kill themselves, also switch back on that pathway. Venetoclax is the only one we have available that's certainly approved or even close to being approved. So those two agents, or those two pathways, are critical to the treatment. They're not chemotherapy, they're targeted treatments, they're oral therapies, largely the ones that are approved are oral. And they're both those two approaches are very effective in CLL, both when patients have failed chemotherapy and in front line, as in previously untreated. So just to talk about that a little bit, the evidence we have, if we're going to cure diseases like CLL, and we have this from across a lot of different hematological malignancies and other cancers, the best time to get the best treatment is early on. So if the disease is allowed to grow through a treatment, it becomes more resistant. And so we'd like to move these therapies to front line to try and get the greatest benefit. We have a number of trials which have shown that ibrutinib is better than chemotherapy in front line, both mainly in elderly patients with weaker chemotherapies, but also against FCR. The challenge is that with chemotherapy, we have a fixed duration of treatment for 6 months or up to 12 months, whereas with ibrutinib, we have continuous treatment with the potential side effects that we see with that approach. And so the trials, by their nature, take a long time to answer a question, because we have to wait until, because first of all, the chemotherapy is actually quite an effective treatment, so we have to beat that. And we also have to collect real data, not just do you feel better in the first year or two, and do you have a better response, but what's it like in 5 or 7 or 10 years. So it's really important that we do large trials with large numbers of patients, and we collect data over a long period of time. I think it's fair to say the movement generally and globally, and you'll know this, is away from chemotherapy towards targeted treatment, but we're still collecting data on that. And then so the next phase of trials, and we've done those with Clarity, and some of you will be familiar with the Clarity trial, and with FLIR, is combining those two new treatments together. And so logically, to corner the leukemia, you would treat it with more than one disease, with more than one treatment that are mutually exclusive in the way they work. And that's the way we've generally moved the treatment of cancers and other diseases forward. And that's certainly looking very impressive in the early trials that we've been doing. So the basic treatment in the UK now, and this is driven to some extent by what's not only what's approved, so drugs have to be approved in their indication, but also have to be funded, and that is different in the devolved countries. So NICE is responsible for England and Wales, so the Scottish Medicine Council is for Scotland, and so slightly different but very similar. But the drugs have to be approved, and then they have to be approved by NICE for funding. And so we are currently in a situation outside a trial that we don't have funding for targeted treatments in frontline, apart from patients with the, as I mentioned before, with poorest disease, 17p deleted disease, that won't respond to chemotherapy, but do respond to these new therapies. Hence our trials. We've had a very strong, one of the probably the 2 or 3 biggest groups for trials in the world, and we over the last 15 or 20 plus years run several large trials, and the ones we've been doing recently are the FLIR trial, which is a very important study. It's the largest CLL trial globally ever. We currently have 1,400 patients from around the UK in FLIR. We're targeting around 1,500 to 1,600 patients, so we're almost completed. It started in September 2014, and there's still patients are still on treatment, of course. We still don't have the results. We're getting close to the first results from FLIR. COVID might push it back a little bit because of the sites being affected. So I'm hoping it'll be this year, maybe next year, we'll see the first information from FLIR, but then there are other questions that will come later on. FLIR compares the new therapies, so ibrutinib or ibrutinib plus venetoclax against FCR chemotherapy. And as I said, FCR can be very effective, so we need a long trial. I shall just mention acalabrutinib. So ibrutinib, I mentioned, was the drug which stops the cells growing. And ibrutinib is a very specific drug that switches a switch off in the leukemia cells that stops them being able to grow. Even though it's targeted, it switches off probably about 9 or 10 other switches unrelated to CLL, and that leads to some side effects. And one of the challenges is to try and reduce the side effects of these drugs, particularly as that patients are on them for a long period of time. And acalabrutinib and zanubrutinib, tirabrutinib, there are a number of them, are the next generation ibrutinibs, so if you like, that are more specific and seem to be at least as effective as ibrutinib in our early studies. And the reason I mention acalabrutinib is that with the COVID crisis, acalabrutinib has now been approved in America for CLL. It has not yet been approved in Europe, but is being considered and will be approved almost certainly in the next 6 to 12 months. That would be my estimate. But AstraZeneca, who make acalabrutinib, have made this available during the COVID crisis and until approval and funding in the UK for patients who would fulfill their criteria, which are basically patients who would not be fit for FCR and don't have 17p deletion. So many hospitals around the country are now using acalabrutinib as a less intense treatment for CLL, if you like, and requiring less visits to hospital, which obviously in the COVID era is important. So that's where we are from a treatment point of view, and I'll answer questions later on if you wish. So moving on to COVID-19 and the last challenging months for all of us, I think. So just generally in the hospitals, we've had, this is the first time in my career, and I qualified in 1985, that genuinely there's been a risk to people working in hospitals of the disease we treat. And it's been a very strange environment for some of my friends who've ended up on ICU with the infection. So it's an unusual situation generally. I think this was in January, February, it was clear this was going to be a problem, and the hospitals started preparing for the COVID before the lockdown. There was a lot of fear that we would not be able to cope. We saw that in certain other parts of the world where there were not enough ICU beds and there were major issues. What that meant is we cut back a lot of our routine work. So virtually for a period of time, actually all of our patients, certainly in my clinics, and most of my clinics are CLL or one other disease I manage, became telephone clinics for at least 6 or 8 weeks. We stripped down the wards. In Leeds, we normally have about 50 inpatients for haematology. We probably went down to less than 10 of the patients who really had to be in for acute leukemias or really couldn't be out. Hospitals partitioned patients into COVID areas and non-COVID areas. We had the challenge of testing, of course. How reliable was the testing? Because we didn't really want COVID patients who weren't diagnosed in a clean area where we might have non-COVID patients. In fact, for example, if we had a patient normally going on to intensive care, we would follow the patient to intensive care generally, and we would manage them through that stay. During the COVID time, we weren't allowed to go on to ICU as a haematologist because we would fear bringing the infection back to other patients. And so there was a very great change in the way that hospitals worked. And I think it has been very effective. I think generally hospitals around the country managed, we've never run into a problem where we couldn't ventilate a patient or where ICU was overrun. And in fact, in our cancer centre in St James's, we didn't have patients creeping into our clean area. So I think that was a very effective. We built the Nightingale Hospital on Harrogate and other places, and which was really never used, but was an important development, I think, and may hopefully will not be needed in the future. So that's what's generally happened. I think over the last sort of 4 or 5 weeks, we've started to relax the lockdown. In fact, we're starting to see patients now in our clinics. I saw, I think, 13 or 14 patients in our CLL clinic on Monday. We'd normally see 50 to 70, so we're starting to see patients we need to see. We're still isolating patients as much as we can. The challenge for telephone clinics for us, for CLL, is we're not getting blood tests, and patients really don't want, and we don't want them coming out of shielding, or we didn't during the height of the crisis. And so we've had to make judgments whether we felt patient should have blood tests. We managed to ship drugs into patients' homes largely, and I think now we're slowly relaxing that sort of shielding. In terms of risk, and there's been in terms of for CLL generally, we know from our previous information for many years that patients with CLL have an increased risk of infection. CLL is a disease of the immune system, and treatment and progressive disease can lead to a reduction in immunity, to antibody levels in the blood, and to what we call cellular immunity, so the ability to fight infections. Generally, about 1/3 of patients will report infections with CLL generally, and that increases as we treat patients although they have progressive disease. And so we know from other organisms or other infections that this is a risk. And therefore, we've always been very cautious about our patients with COVID, and I think the guidance from the shielding guidance from the government, which I wasn't involved with, and I'm not sure that haematologists were directly involved with, which said leukemia patients should be shielded, is probably it's very conservative, but a reasonable approach at that point. What data do we have? Well, there's been a very large UK-based study of I think 17 million of the population looking at COVID patients recently to look at risk factors for the severity of infection with COVID if individuals get it, and there's a large number of COVID patients in that study. And what it shows, I think, is that patients with hematological malignancy, it didn't split CLL out, have about a 4 times the risk of having severe COVID if they get COVID and dying of COVID compared to the general population. Now that includes a wide range of diseases. It's more in patients who are on treatment or close to treatment. And as I said, CLL wasn't separated out from hematological malignancy, but I think it is reasonable to consider CLL patients to have a similar risk because it is an immune disease. If I look at the data we've generated, we've seen a number of our patients with CLL who have had COVID and have not all done well. So I think that risk that I mentioned is probably correct, that if a patient gets COVID, there's a greater risk. In FLAIR, we're watching the patients in FLAIR very closely. There are 1,400 patients in FLAIR. some of them have finished treatment some time ago, and some of them are still on treatment. We've had 18 suspected or confirmed cases of COVID at the last count, 14 confirmed, 4 suspected. They will only be the patients who are admitted, because we aren't testing everybody who might have symptoms, and so it's possible there are more mild infections it's likely there are more mild infections we haven't seen. What did we learn from that cohort of patients? Well, first of all, most of those cases were early on. So since shielding came in, and in the last 4 to 6 weeks, we've seen very few, I think 1 suspected patient, and all the other ones were early. So shielding and the reduction of the virus in the community is helping. We've had 2 deaths in those patients. That I don't know what the denominator is, so I can't say how that how significant that is. But one would say that it probably supports the data that the patients are at some increased risk if they get COVID. We have no data on early stage, as in the first presented, and patients later, as to whether there's a risk for stage A disease and whether there's a different risk. I suspect there would be a different risk, but I do believe that all patients would be at some risk and should be considered to be so in that case. The effect of COVID on the trials, well, it's basically what we had within the UK is a diktat from the pandemic plan that non-COVID research would stop. And so we didn't close Flare down or the other trials, but we stopped recruiting patients in effectively because patients weren't coming to hospital, and we could often delay treatment. So for a couple of months, we've had a few patients included, but now we're picking up again as patients need to be treated, and Flare is a reasonable option for them. There were some questions about immunoglobulin and vaccines. So first of all, IVIG, someone asked a question about when would the supplies be freely available again. Well, first of all, immunoglobulin replacement is in short supply all the time. So we manage stocks of immunoglobulin at all times. And so we have, fortunately, our patients with CLL are priorities for immunoglobulin if they need it, if they have infections. We have, in my practice, we usually give intravenous immunoglobulin every 4 weeks. We've stretched it to 6 weeks to reduce the exposure of patients to the hospital, rather than because of the supply of immunoglobulin. And so we're in a similar situation, certainly in Leeds, that we have immunoglobulin to the same level as before. In terms of the vaccines, the COVID vaccine will be important. I suspect that the COVID infection will be going down before the vaccine is having an impact on it, but it will probably, hopefully, control subsequent infections with COVID in the future if they were a danger. Some of the vaccines that are being trialled, I think the Oxford one is a live vaccine, and therefore we wouldn't want to give it to our patients. We shouldn't give live vaccines to CLL patients with CLL. But some of them are also killed, so it may well be there's a vaccine that will be suitable for our patients, but not in the near future. And there's a question mark about how well people will respond. So I think that the strength of the vaccine is getting rid of this virus from the community. Shingrix, the shingles vaccine, there's been questions about that. It's not yet licensed in the UK. It has been submitted for a license as December 19 for prevention of shingles in patients with immunocompromised patients. So the reality is it won't be widely available until at least next year, I suspect, because it takes a long time for these licenses to be approved, and so it's not widely available in the UK. And then just a message about shielding. Well, shielding has been very effective, and I think many patients have shielded, and some patients cope with shielding very well. Other patients, because of their social circumstances, other issues, really struggle with the whole concept of shielding. And we've seen the extremes. And in some patients, continuing shielding is dangerous because they can't cope with the isolation or other issues. Having said that, the risk, what shielding does is stops you being exposed to the virus. And I think the recent, although it was rather on the hoof, the recent change in the shielding guidance, which we went to where was coming a week last Sunday, it's probably sensible that as an individual who is shielding, I think going out for a walk but keeping a distance from patients, I think Paul mentioned about that, is sensible, but you have to take responsibility. You do not want to be being exposed to the virus, and as the virus gets less in our community, then the risk of coming across it is obviously going to be smaller. But that's going to be different to going into closed spaces, to go on the tube and those sorts of things where the risk is greater. Remember that the masks will, obviously as part of the plan, protect other people, not you. So do not assume because you're wearing a mask you're being protected from a virus. It's stopping you spread it to someone else. And so social distancing, hand washing, and trying to avoid crowded areas, going out when there's not crowds is sensible. I'm an optimist. I think this virus will go down over the next few months. Looking at what's happened in other countries, China, well, we don't know about the dates, of course, but Italy, Spain, France, the risk of the amount of the disease has gone right down. So that will happen here. We're a bit behind those countries. And then finally, before I finish, travel, I would be anxious about traveling until we know that the virus really is under control and where we're going to is under control. So I know it's difficult, but we still need to avoid being exposed, I think.